have to be the one that led or conducted the evaluation, but again, as long as you participated in the implementation of the strategy and are part of that collective group to work on and implement that strategy, that's fine. So don't think you have to be the one to conduct the evaluation as long as you're involved in that collaborative process. Documentation 4, required documentation 2 could include, for example, an evaluation summary, a report, it could be meeting minutes, or it could be a presentation showing evaluation findings about needed process changes or the impact of strategies on meeting your intended goals. The third measure is 7.2.1, which is to collaborate with other sectors to improve access to social services. And there's one required documentation for this measure that calls for 2 examples that must be dated within 5 years. Required documentation 1, it calls for multi-sector implementation of an effort to improve access to social services or to integrate social services and healthcare. So the intent of this requirement is to demonstrate how your health department, in partnership with others, such as healthcare, social service, behavioral health providers, has implemented strategies or systems of care designed to connect clients to needed resources. And this could include coordinating services for populations who are vulnerable or at risk, through data exchange systems designed to identify individuals with high service utilization, working with providers to develop systems to assess social needs of clients, could be setting up systems for referrals, or developing coordination systems to integrate social services, behavioral health, public health, and primary care services. Again, I want to point out that the health department for this measure does not have to be the one to convene or lead the collaborative process, but the department would need to show how you are involved in implementing the strategies. Then the fourth and last measure within Domain 7 is to collaborate with other sectors to ensure access to care during service disruptions. And this measure has one required documentation, which calls for one example that must be dated within 5 years. The required documentation asks for a collaborative strategy to ensure continuity of access to needed care during service disruptions. And the intent of this is to demonstrate how your health department collaboratively contributes to ensuring continuity of access to healthcare or social services within your community in the event of a disaster or disruptions to the delivery of services. Strategies could include establishing systems of care at alternate locations as a result of an emergency. Could be ensuring access to prescription drugs if patients are temporarily unable to access pharmacies due to the emergency. Could be creating alternate strategies for families to receive food support if meal programs at schools are disrupted, for example. Could be contingency planning to address the short-term access challenges resulting from the loss of a hospital or a clinic or loss of a service due to the emergency. Could be providing assistance with housing in the face of rising unemployment rates due to an epidemic. So the list of examples for this one could go on and on. Also here, the focus doesn't have to be on something that's been implemented. We get that question a lot where people are like, well, we haven't had an emergency come up since COVID where we've needed to do this. So it can be strategies that you've planned. Maybe you haven't implemented them yet. So getting ahead of an emergency. So thinking ahead, contingency planning. So it can be a strategy that you've collaboratively planned or implemented. Either route is perfectly fine to provide as your example. So those are the 4 measures. We did spend a little bit of time looking across the documentation that we've received from tribal health departments and thought it might be helpful to call out some of the partners that they tell us they work with to address healthcare access. And then, of course, you've got the two other presenters on the call today from tribal health departments who can speak to their own experiences and their own examples that they've used. But you'll see here on the slide, these are some of the partners in addressing access that some of our other tribal health departments that have been through the accreditation process have identified for Domain 7. I was also asked to talk a little bit about authentication and branding of your documentation. So this isn't just specific to Domain 7. So this would be a little more broader, general to all documentation that you might be preparing for PHAB accreditation. So what do we mean by authentication? Ultimately, we're looking for some evidence that it's a document of or in use by your health department. So ideally, that would be your health department's name, abbreviation, or logo on the document. Very clear, this belongs to Ho-Chunk Nation Health Department. But we also realize that's not always the case on every document. So there's lots of ways you can demonstrate authenticity on the document. It could be a signature if it's something that needed to be signed, and you can identify, this was our health department director that signed this agreement or whatever it is. It could be someone's name that you identify. This is a health educator at our health department named Susan, and you highlight in these meeting minutes that Susan attended this meeting. That's your authenticity. It could be an email address of an employee at your health department. So there's any number of ways. We're pretty liberal on how we can identify that, but we just need some indication that it's a document of or in use by your health department in order to, confirm it's authenticated to your department. A question we often get is when it's not your documentation. So I mentioned meeting minutes. So maybe it's a meeting your health department participates in, but you don't run the meeting. So it doesn't have your logo at the top. It doesn't have your health department name at the top. But so in those cases, sometimes maybe you need to provide some supporting documentation to show how your department's involved in that work or whatever's being demonstrated by that document. So the supporting documentation can either show how your department was involved in the work that led to the development of the document, or it could be something that indicates the work was done on behalf of your health department, such as an agreement. So if there's a formal agreement in place that maybe for the measure I was talking about where the evaluation needs to be done, maybe your health department has an agreement with another group that conducted the evaluation on your behalf, but the actual evaluation report maybe doesn't have your name on it. But if you could show the agreement, you had that work done for your department, that would be the supporting documentation you would want to include to give that authenticity. Or maybe your health department just serves on a committee or some kind of coalition within the community, but again, your department doesn't run that meeting. So giving the meeting minutes, showing who attended from your department, highlighting that, making it clear this is an employee at your health department. Because we're not going to know that. I'm not going to know from your name that where you work, because we're outside eyes. We don't know all of your staff, of course. So you really need to make that clear to us. Could be an email distribution list showing, we're part of this group. Could be any number of things, just to give you an idea of ways you could potentially demonstrate that authenticity through supporting documentation. The last thing I wanted to share were just some resources available from PHAB. Number one, for any questions you might have. If they're measure specific, you want to ask a question about the intent of a specific measure or requirement within a measure, you can submit those to our Ask PHAB email address that you see here on the screen, and I'll drop several things in the chat once my presentation is complete for you, so you don't feel like you have to write these down. So any EFAB questions you might have, measure specific questions, accreditation process questions, those can all come to our Ask PHAB inbox. And then our entire accreditation and recognition team monitors that inbox and will respond to you. Also available to you whether you're in process or not. And the Ask PHAB inbox, you can email whether you're in process or not. If your health department is thinking about it and just looking through the standards and has questions, that's open to anyone. You don't have to already be a PHAB customer to email questions to Ask PHAB. Same goes for the PHAB Learning Center. There are parts of the Learning Center that are open to anyone. So if you're thinking about accreditation, want to learn more, there are several modules and courses within there to help you learn more about accreditation and our various programs. And you can email our education services email and they can set you up an account. And if you want accounts for other people within your health department, you can request that as well. Within the Learning Center, there's the standards and measures are in there. Those are also on our website, available to anyone. But you'll also find the documentation forms, which are basically the cover sheets that are required that you include on every single document or example that you upload. We require those for you to indicate specifically where each of the required elements are found within the documentation you're planning to provide. And I listed it here as a resource because you can use it almost as a checklist on your end. So as you're preparing documentation to submit, use that as your checklist to make sure is everything that needs to be included in this document included. Is it there? And because you're going to need to specifically identify this is the page number that this required element is demonstrated on, and you're going to put the page number on that cover sheet, on that documentation form, and you'll have the opportunity to add any notes or context about that element or that requirement on that documentation form as well. So we consider that to be a resource for you guys. And of course, the standards and measures include very detailed guidance on every single measure to kind of help you understand the intent, help you identify types of examples that you could potentially use. But again, if any of that's not clear, please reach out to Ask PHAB with any of those questions, and we're happy to help you. What we can't do when you email Ask PHAB is we cannot review your actual documentation and tell you if that's going to meet the intent or not. We're only allowed to review your documentation once you officially submit it within the accreditation process. But what we can do is help you understand what's required by that specific measure. So you understand the intent of the requirement, so you can decide on your end if the example you're planning to provide will meet the intent or not. So I hope that makes sense. Also available to anyone, whether you have started through a PHAB process or not. So open to anyone is our new accreditation coordinator training. I'll also put the link for that in the chat in a few minutes. But that's a good place to start if you're just thinking about it. We do have a cap on two staff per health department are allowed to join that training, just because we have a cap on the number of participants we can have. But that is open to anyone. I highly recommend it, particularly if you're just learning more about PHAB and accreditation. That's a great starting point. One last resource I wanted to point out is we are always looking for more volunteer site visitors, particularly those with tribal health department experience. We don't have a ton of health departments currently in process or applying that are tribal health departments. But when we do, it's very important to PHAB, and I'm sure important to the tribal health departments, that the reviewers we assign to review their documentation be true peer reviewers with tribal health department experience. I fully know and understand that no one at PHAB is a tribal public health expert or subject matter expert in any way. It's a totally different culture. There's lots of different contextual differences from a tribal health department to a governmental public health department. So we recognize that and really want to grow our pool of tribal experienced site visitors. So I will drop the link in the chat if that's something you're interested in. We would love to have you apply. I always tell folks that I think being a site visitor, it's really a win-win for PHAB and you and your health department, because if your health department's interested in accreditation, it's a great way to learn more about the process. You'll get an inside scoop on what the review process looks like from the other side of the table. You'll get to participate in a site visit, so you'll get that kind of heads up on this is what a site visit is going to look like. So it's really almost like training for you and your own health department to prepare you for going through the process. So again, it's a win-win. We need more tribal reviewers. So if you're interested at all, please do apply. We're doing a training in August. So if you're eligible, we will invite you to that training. Again, I'll put that link in the chat when we wrap up. And that's all I had. That was quick. But are there any questions that I can answer now, or do you want to wait until the end, Jessica?
If anyone has any questions that we can answer while we transition speakers, we can welcome them at this time.
Thank you. I'll keep my eye on the chat. So if you think of something, feel free to drop it in there, and then I'll work on adding some of these links I promised I would share into the chat for you as well. So thank you.
Awesome. Thank you so much, Brittany. All right, so next up, we want to transition to Chelsea. Make sure she's still on here.
I'm still here.
Okay, so Chelsea, the floor is all yours. You should have sharing capabilities whenever you're ready.
Okay, good afternoon.
So,
I'm just gonna briefly kind of introduce myself again. I work at Yellowhawk Tribal Health Center, which is part of the Confederated Tribes of the Umatilla Indian Reservation. I do accreditation work here in public health, but I also do grant work. I'm an enrolled Klamath tribal member, so I'm not from this tribe, but I work for this tribe. And I've been here for about 5 years working for the C2IR. So, and then a little bit about Yellowhawk's accreditation journey. We were accredited in 2020, September 2020, and we are a tribal health clinic that provides wraparound services. So in our building, we have medical, dental, behavioral health, optometry, public health. We have a bunch of services that we provide, which is awesome for our community. I think it makes PHAB just a little bit complicated for us, but we recredit in 2025, so we're coming up on reaccreditation. In our initial accreditation, and I wanted to kind of talk about where we were with Domain 7 in our initial accreditation, because it's a little bit different than where we've gone with reaccreditation. But we actually applied for a grant in our initial accreditation to create this organization called the Oregon-Washington Health Network, which is OWN. And OWN is now its own organization. It does all its own work. And originally we were just one small part of it, but it was geared at addressing access to care in the Oregon-Washington area here. And so for Domain 7, originally, we submitted a bunch of work that OWN ended up doing and that we ended up collaborating on as part of this grant process. So we had like a behavioral health action plan we created. There's peer recovery mentors. We did conduct an access to care assessment with OWN and other organizations back in like 2018, 19. And then we were able to get telemedicine services up and running at some different healthcare organizations in this area. And then on top of that, for some of the other measures, we did things like collaborative flu shot clinics with our CHRs. And then we have a program here at Yellowhawk called Family Strength, which is a behavioral health program geared toward creating healthy, thriving families. And that was where we had went with Domain 7 originally for our initial accreditation. Now, when we talk about Domain 7 and access to care, we're still kind of building our body of documentation for domain 7. But for 7.1.1, when we talk about an assessment on access to care, we have combined kind of multiple assessments to address this measure. So we have our 2021 community health assessment where we did ask some questions in regards to access to care. It was just one portion of that assessment. But that assessment was done in collaboration with multiple organizations here at the tribe. So we did it with our tribal housing department, our Department of Child and Family Services, our Planning and Public Works Department, our Behavioral Health Department, our medical department. It was kind of a multi-departmental and organizational collaborative effort to do that community health assessment. We also every 3 years do an elders needs assessment, and generally when we do our elders needs assessment, we collaborate with our Department of Child and Family Services. They have a elders division specifically within the tribe, and those, us as a group and them as a group, we are the ones kind of on the ground getting the elders to do the assessment and doing outreach. And we have obviously a lot of access to care questions within that assessment. And then we also just recently last year were awarded the Tribal Maternal Home Visiting Grant. And as part of that grant, we have been doing a community needs and readiness assessment. And we have been working, we have a contract with an evaluation team called NPC Research. And we have been working with them on that assessment. And we do kind of key partner interviews. We identified, I think it was 11 different people within the community and also within organizations in the community to do key partner interviews with. And from those interviews, we have kind of created, obviously, a report about what that assessment is telling us in regards to maternal care in our community. So by combining those different assessments, we hope to cover 7.1.1. There are some kind of strengths and challenges with, I think, this documentation that we have so far that I'm going to kind of talk about. And I saw some questions about where we're at in the accreditation process. Or sorry, maybe that was to someone in the chat, but we come up on reaccreditation next year. So our strengths, I think, in this documentation is that we do have a lot of partners in terms of data evaluation, which has helped us immensely with kind of analyzing some of this data in terms of access to care. We partner with NPC Research, which is an organization that we have worked with on multiple grants. And so we kind of have a long-standing relationship with them. But we also partner with the Northwest Portland Area Indian Health Board and their Tribal Epidemiology Center. They helped us with our community health assessment. And so having those partners in terms of data evaluation has really helped us make some reports that we're able to kind of present to the community and to our stakeholders. We have a lot of grant funding in terms of our tribal home visiting program. So that's helped us immensely kind of with this CNRA process and getting all of that information and community input for our assessment. We are I think we're pretty assessment heavy here. We have a lot of different assessments to pull from. These are just the 3 that I thought best fit this measure, but we have a lot of data and a lot of data primarily that we've collected that we can kind of pull from in terms of our community. So, and we also just completed last year our annual report. We did our reaccreditation assessment so that we would have a better idea of where we were in terms of our reaccreditation process. And I think that's helped us a lot kind of identify those gaps in some of these domains. And so if you're working on reaccreditation and you haven't done that yet, I would recommend it. It was helpful. Some of the challenges that we have, I think, with this measure specifically is that our CHA has pretty limited data in terms of access to care. We asked a lot of questions about Yellow Hawk specific care, but we didn't necessarily ask as many broad questions about access to care for the population and for our jurisdiction as a whole. And so that's something that if you're in that process of doing a community health assessment, and you are thinking of it in terms of your specific clinic, it would have been helpful, I think, if we had done that process from a much broader point of view. Our other assessments are geared toward very specific populations. So our elders needs assessment, obviously, and then our tribal home visiting assessment. Those are specific populations within our general population. So that kind of, doesn't give us a broad overview of access to care in our jurisdiction. And then when we talk about primary care and behavioral care providers in this measure, one of the things that I have recently kind of discussed with PHAB and gotten guidance on is that because Yellow Hawk has primary care and behavioral health included in our organization, there is a little bit of a distinction to be made in what we term collaboration. So collaborating internally with our medical department and our behavioral health department doesn't satisfy collaboration for all measures. It only satisfies it in terms of some measures. So that's something that we've been considering and kind of reviewing our domains and our measures and making sure that we are also including primary and behavioral healthcare providers from outside of Yellow Hawk external to us. But it is difficult because we are the primary healthcare provider for the reservation. And so when we talk about collaborating externally, it usually means that we're collaborating with the county or collaborating with healthcare services outside of our reservation that some of our population may access, but it's not Yellow Hawk specific. I mean, our goal as Yellow Hawk obviously is to have all of our reservation population and all of our AIAN population have services at Yellow Hawk, but just being aware of kind of that distinction in our case is important. So one of the things that we're looking at in terms of creating kind of a solution to some of these challenges, our gaps in domain 7 is creating kind of a supplemental collaborative report where we can reach out to some external primary and behavioral healthcare providers and agencies and kind of see, can we use a lot of this data to create a report on access to care within our jurisdiction specifically that's more collaborative, that's not just within Yellow Hawk or within the C2IR, that kind of reaches out to healthcare partners in general. So. And then for 7.1.2, we have two different groups, and this is a measure we've done internally as we are kind of more of a super agency. We have multiple departments within our agency. And so when we talk about 7.1.2, we've looked at two programs that we run here in our clinic, but they're programs that are a collaboration between multiple departments within our clinic. So for our first kind of example for this measure, we have a self-measured blood pressure program, and we also have what we call a public health integration desk. So it's a collaboration between our medical departments and our public health department to enroll people in this self-measured blood pressure program, that they're able to kind of track their blood pressure at home, and then CHRs kind of help them through that process. They do regular check-ins with them as they're going through that process. And then they loop back with the medical providers, and the patient is brought back into medical to go over kind of what they have found in their self-measured blood pressure journey. And that's all ran by our integration desk, which is a position within our medical department that is actually occupied by a public health staff member. And their entire goal is to create an integration of services between our medical department and our public health programming. So they integrate more than just our self-measured blood pressure program. They also do like our fitness programming, our dietary programming, And basically, they just ensure that patients, when they're done speaking to their medical provider, that they have a follow-up with a public health staff member to talk about other programs that are available to them that might be helpful or apply to them. And then they're able to create referrals for that patient. And we just started that program last year. And so we're in the process of gathering evaluation data for that. And so we're hoping to use the evaluation findings of how that integration desk position is going and how that has changed kind of the referral process between our medical departments and our public health departments. The second strategy is a committee that we call the prenatal loop, and that has come out of our home visiting program, and it's a collection of multiple departments here at Yellow Hawk, including like admin and business, behavioral health, dental, coding. And really the goal is that when we have an individual come in to Yellow Hawk and they're pregnant and they're coming in for their first care, that they are being introduced to all of these different departments that play a role in the health of them and their child, and that they're kind of meeting these milestones every time they come in for an appointment. And this is something that we have always had, but we are kind of improving over these last few years in terms of what that policy and procedure looks like, what our patients are being introduced to when they come into the clinic for their first maternal appointment, and kind of where we want to fill in some of the gaps that we have seen in our maternal health. For 7.2.1, one of the strategies is still under review. We're currently working on health-related social needs here at Yellow Hawk and what our process and our policy is going to look like. So that's something that's in the works. I don't have documentation necessarily that shows that we have a process set up and in place. But it's something that we have been meeting with our medical department about, and that we have been identifying outside organizations and partners to begin that process with. But one process that we do have in place, a strategy, is our elders quarterly resource meeting, which is a meeting that we actually host, but it's attended by multiple departments within Yellow Hawk, as well as our OHA representative, CAPCO, which deals with like housing and food resources out here, DCFS Elder Services, and our tribal housing department. So we have multiple partners come to that meeting, all with the goal of ensuring that our elder population is receiving the access to social services and healthcare services that we need. And so that meeting has evolved a lot over the last few years, but generally all our partners attend. If there's resources or processes that we need to improve that we've identified as having gaps or being difficult for the elders to navigate, then we kind of problem solve what that should look like. And it's a meeting, so there's meeting minutes and things like that in terms of the documentation of that work. And then for the last measure within Domain 7, we are using our tribal emergency operations plan. So Yellow Hawk is within the Confederated Tribes of the Umatilla Indian Reservation, and their emergency operations plan identifies us as partners, and we went through the process with them on a number of services. But in terms of social services, we're under ESF 6, and we're identified as being mental and emotional crisis management within that. And so we are responsible for providing, if the need were to arise, emotional support during a crisis, death notification to families during a crisis, and critical incident stress debriefing. We are also in the tribal EOP, they have grouped different departments into a human services group for ESF 6, and that group kind of coordinates together as a team to help with food, clothing, and shelter. And so there's different roles that Yellow Hawk plays within kind of that human services group, and if a need were to arise. And there's like secondary roles that we also play within that same group. So Our primary is mental and emotional crisis management, but we fall kind of within a greater group. I wanted to share this. This is something that as a accreditation coordinator with my department, I have recognized that a lot of the PHAB measures tend to go back to like 3 big keys. And so one of the things that I tell my department is when we're doing new projects, when we're creating new work or improving old processes, how can we look at the collaboration, the equity, and the either analysis or evidence base that goes into that work. And I think that really focusing on who are our partners, seeking out partners, who are the people that need it most, what areas do we most need it, and how are we informing our work and using the data that we collect is something that we try to focus on as a department here as we go through our work. And it obviously ties directly back into PHAB. My contact information is here. I don't know if Jessica's going to share these slides, but if you want to take a moment to get that, I'm happy to answer anyone's questions. And if you wanted to follow up over email, I'm happy to respond to anyone's emails as well. And I don't know how much time we have for questions, Jessica.
We're right on time to transition to Candace. So if we could hold questions till the end, that would be perfect.
Perfect.
Thank you so much, Chelsea. All right, everyone. We are going to move over to Candace Dunlap from Ho-Chunk Nation for our final presentation. I see the questions about the presentation slide, so we'll collect those at the end of today's session and send those out via email to the registrants along with the evaluation link. All right, Candace, the floor is all yours when you're ready.
Thank you. Hello again, everyone. We're going to be talking a little bit about the history of Domain 7 when we went through accreditation, but the rest of it is kind of sharing in real time what we are doing. So we were accredited in 2022, but we were accredited under version 1.5. So a lot of the things that we did was kind of in the old Domain 7 and translating that into the newer 2022 version. Most of the documents that we used were related to a community health improvement plan from a local health department. So we were not the holders of the community health improvement plan. We were a partner in that process with one of the counties that we work with. And then also our own community health assessment. And what we found is it's hard to have perfect documentation. We ended up with an ACAR, and some of the feedback that we still got are areas of not specifically addressing healthcare, geographic differences, what our jurisdiction looks like. We cover 15 counties in the state of Wisconsin and 1 in the state of Minnesota. So partnering with specific counties for some of this documentation. And this was really helpful in getting a lessons learned as we go into reaccreditation for us is in 2027. And what we're doing now for specifically Domain 7. So we're tackling this essentially from 3 different areas that all build on each other into kind of a culmination. So the first way that we're looking at this is a program inventory. And I put some timelines in here to kind of show that this is still a work in progress. And this is very much in real time. So our program inventory, as we were coming off of COVID and potentially moving into our community health assessment, do we do a community health improvement plan from our 2020 CHA? Things have changed. In order to understand what needs our community has, whether it relates to overall public health, environmental health, or access to care, what post-COVID are we currently offering? We're in our community health assessment. We're in the heart of it right now. So we started the planning of that in 2023. And then our public and environmental health report, we have 2 versions of these. So I'm going to explain each of these just a little bit more. So as I mentioned, we wanted to understand what are we currently offering? How have things changed? In order to look at differences between what community has identified as needs or gaps in access to care, we need to understand what our offerings are. So we took all of the community-facing divisions, and for our health department, it's all of these divisions listed here. And we developed a repository, only for internal use at first, in what is the program or service being offered, what's the description of it, and who is eligible. Is it only to Ho-Chunk enrolled individuals? Is it to Ho-Chunk Nation employees who might be non-tribal? Those types of things. So we can get a baseline of what services are we currently offering. This was beginning in 2022. So that was just one component of it. And then next, we're in the community health assessment phase of it. So we're tackling this in 2 different waves. We're starting with a qualitative portion of it, and then also moving into a quantitative portion of it. Where we currently are as of the end of July is we are in the heart of our qualitative portion, which is community conversations. We're holding essentially focus groups for individuals to answer questions. I have some examples of questions here. This is not a list of all of them, but some of them that we're highlighting. And how are things in your, what are some things in your community that influence your health, good or bad? What makes it difficult for you and your family to be healthy? Challenges and ways to overcome those challenges. And asking health equity without saying health equity. So who in your community do you feel needs more help than they're currently getting? What kind of help do you need? And we're also specifically asking for feedback from groups. So we have sessions specifically centered on conversations around veterans' needs, conversations around elders' needs, youth needs, people who are parents or providing any kind of caregiving. And then we have sessions open for everyone. And the goal of this is to get information and identifying gaps in what community members identify as needs and what we are currently providing, but also using this to inform our quantitative portion or our what is going to be a survey. So if we want to know a little bit more, we want some numbers aspect of it, using the answers from this qualitative or the community conversation component of it in our qualitative. And if we find that the community conversations have identified something that we have on our program inventory as it's something that we actually provide, is it mostly just a matter of people don't actually know that that service is available? So being able to wrap all of that into a hopefully not too long type of survey. And as I mentioned, we're still in kind of the assessment phase. So everything in this is really in that 7.1.1a component of it. And then next we have what we call our public and environmental health report. This is looking at a lot of secondary data. So we pull information from a host of different places. We are very fortunate to have an epidemiologist on our staff who does a lot of the legwork in this. But we get internal data from our Office of Enrollment. We get internal data from our Department of Health programs and our EHR, but we also get data from external sources. So in the state of Wisconsin, we either get information from the DNR or the Department of Health Services. And we also have a tool that we're blessed with called the Wisconsin Electronic Disease Surveillance System. In day-to-day operations, it functions as a way to report our Category 1 or Category 2 communicable diseases, but it's also a platform for us to be able to get data on communicable diseases, and then information from the US Census or the CDC. I did include a link in this when I share the slides, and it pulls you directly to the report, but it pulls information on how often individuals are accessing prenatal care, whether it's the first trimester, second trimester, or third trimester. We have the social vulnerability index in there. So it's a combination of that program inventory and what we currently offer, and then what the secondary data look like, and combining both of them to just have it in one nice place. And so what have been some challenges and hurdles? Specifically with our program inventory, it already needs updating. We completed that aspect of it in the internal repository in 2023. And as things change, as new funding sources come in or as funding sources leave, those are changing. So having someone to be able to dedicate time to updating that in real time. Our community health assessment, we saw a lot of delays in the process outside of the health department's control. We operate with an institutional review board or an IRB. Through no fault of their own, there were delays in the process. So just the amount of time that it can take to even get to implementation. We're hoping to be implementing, I think, in the end of April, early May, and as of July, we're now implementing. So recommendations in being okay with delays and planning for those ahead of time, even delays in contract processes and getting resolutions for things. In our public health and environmental health report, getting access to internal data, it took us quite a few years to develop a relationship with enrollment in the purpose of this report, specifically around death statistics and causes of death. External data as well. A lot of the data that we get are attributed to the state of Wisconsin, and we can break them down by tribal or non-tribal. But that doesn't necessarily get us to the level of Ho-Chunk Nation specific individuals or Ho-Chunk Nation specific data. So we're relying a lot on that tribal versus non-tribal for the counties that we specifically serve, and translating the data. It's a very wonderful report, but if individuals, I think of our own council or legislators, don't understand what that actually means, or us internally in the health department, how are we using that data? It doesn't do us a lot of justice, just kind of making that report. And domain 7 as a whole, I know Chelsea kind of alluded to this as well, the separation of what is public health and what is clinical care. We as an entity have pharmacy, we have optical, dental, clinical, behavioral health, but then we also have community health, public health, environmental health. So how do we collaborate with one another when we're still internally in the same organization, but also divide ourselves? We ran into some issues in the first time around in trying to submit documentation that came from our clinical side of things, and it doesn't fulfill the public health portion or piece of it. So making sure that all of those who are on board and working on annual reports or reaccreditation understand those distinctions and are reading through the standards and measures in doing that. And one hurdle and challenge for us is choosing our partners. We have a lot of fantastic local health departments within our 15 county jurisdiction, and we don't have the capacity to be hand in hand through the way partnering on all of their community health assessments and their community health improvement plans. So having to pick and choose in what capacity can we be good partners, and who are we being good partners to? And on the other side, who are we making sure that we invite to the table? Not just within the tribal resources, but also with our county resources, because some of our individuals use county resources and use our health department. And so you're seeing this in real time. Some of the strengths that we have is in 2022, we specifically created a division of public health. And this has been really helpful in kind of teasing out those clinical versus public health components, and having a place for a lot of the public health accreditation things to land, and we can divide it that way. Next steps, we're kind of moving into that part D of 7.1.1. We're finalizing our community health assessment and the report that goes into that, so we can move into our community health improvement process. And using all three of those portions to intentionally work on our community health improvement process. And I will note too that for the public health emergency preparedness and the section kind of in 7.2.2, it's been really helpful to have someone dedicated to public health emergency preparedness, at least a quarter time or at least half time. They're currently conducting tabletop exercises to look at service disruptions, and developing plans in those places. And it works out very nicely when you actually have to implement those, not just for the sake of accreditation. And that's all I have on that. I will entertain any questions, but here's my contact information if anyone has specific questions.
Thank you so much, Candace. Okay, if anyone has any questions, feel free to unmute your line. You can also utilize the chat box feature if you would like to send a message. And this can be for any of our panelists. And while we're doing that, I do want to thank our speakers, Britton Williams, Chelsea Halem, and Candace Dunlap for joining us this afternoon, and sharing this great information, tons of vital information to help you get started, some examples of what it looks like to complete each domain. So we're hoping that you can take this and apply it to your everyday situations that you have in your public health departments. If there's something that you're working through and you need to use these examples, you can get these PowerPoints from them. You can ask them questions. They've shared their contact information. So just one of the ways to improve our networks as we move forward and work together. So lots of thanks in the chat box. And I see Lene has her hand raised. Lene, feel free to chat with us as you're ready.
Good afternoon, everybody. We're currently looking at our access to care documentation, and I was wondering, you guys were both talking about what you're currently doing. What kind of documentation? We probably can't cover it now, but for the initial accreditation, like I know you guys didn't really talk too much about what you initially submitted, but what you're currently working on. And then also, like when you were talking about partners outside your organization that you needed to work with, like I guess I'm just wondering about that. Like, do you have to include people from outside your organization for your assessment and partners?
Yeah, I'll start with your first question. I briefly talked about it, but for our initial accreditation, we had applied for a grant, and we ended up creating kind of a separate organization in collaboration with some other partners. That's called the Oregon-Washington Health Network. And through that organization, we did an assessment about access to care, especially behavioral health care, in our community and in our jurisdiction. And we did a lot of projects through OWN and with OWN, such as like a peer mentor project, and some other like behavioral health, like a suicide prevention project. And when I share my slides, I have links to some of that work that we did with OWN that you'll be able to see. And I also have some screenshots from our assessments that kind of show some of the questions we asked in regards to access to care for our reaccreditation. So our community health assessment and elders needs assessment and whatnot. I have some screenshots in my slideshow that show those questions. In terms of the collaboration, the guidance I received from PHAB when I was kind of asking about a different measure is that when a measure has a requirement to collaborate, the expectation is that collaboration is done with external organizations or community members or groups or individuals outside of the health department. So because we are a wraparound health department and our department includes things like medical and behavioral health and pharmacy and all of that, any work that we do internally, it doesn't always meet that requirement of what it means to be collaborative. And so in domain 7, there's a specification that we collaborate and also that we consider primary and behavioral health. So for us, even though we have primary and behavioral health within our clinic, if we're required to collaborate externally, that means that we have to look for some healthcare partners outside of our organization that we can also do this work with. So in our county, we have a group called Community Counseling Solutions that we partner with on a lot of behavioral health issues that the tribe may not cover completely. And so we can look at that organization as a partnership. We can look at our county healthcare partners, our Umatilla County Public Health and things such as that to meet some of those requirements. And that's kind of, or we also partner with the Northwest Portland Indian Area Health Board and some of the other 9 Oregon tribes to talk about access to care in terms of tribal populations. So we try to look at it in that regard.
And I'll just add to, for us, one of the components that we used was actually one of our local health departments was going through the community health improvement process for their CHIP, and there were different strategies that they were working on. And so we had individuals from the health department on those sub coalitions working on some of those strategies, like I'm thinking Healthier, Sauk County, in terms of physical activity. So that was some of the documentation that we had used, was either reports from the community health improvement plan as a whole, or meeting minutes, agendas for participating in those different strategies. And then some of it was our own internal community health assessment, the last round of ones that we had done. And for us, the partner aspect of it, similar to Yellowhawk, in we are wraparound healthcare. We have dental, optical, pharmacy, etc. So some of the partners that we've worked with is just social services. They are not a function of the health department. They're a separate department. So that could be one of your partners. It's still within, for us, it's still within the Ho-Chunk Nation, but they're external to the health department. And we've used information, meeting minutes, reports with those entities. We also, in the state of Wisconsin, rely on formal partnerships with some of our counties for communicable disease aspects of it. So we have that foundational relationship to be able to actually do formal partnerships for things like community health assessments or community health improvement plans. So they're outside of the Ho-Chunk Nation as a formal partner.
Okay, thank you.
I have a question from Kim Blackhorse. It says, thank you so much for sharing, Candace and Chelsea. Could you describe how external partners can be good partners when sharing data? And what barriers should data partners be aware of so data sharing is better for health centers?
I think one of the main ones is actually collecting tribal versus non-tribal status. We get reports and things from state entities or county entities, and there's no way to identify for us if individuals in the report actually would fall into some of our data aspects of it. Or I think of our communicable disease portion of it when you're getting the demographics, making sure that there is a portion to identify that, whether it's in race, ethnicity, or a separate one in being able to identify that, yes, I identify with a tribal nation. That's been one of our biggest barriers in getting access to data that actually represents what we want from larger sources.
Yeah, we also kind of face a barrier. This is something we've been going through with our home visiting program, especially in that community needs and readiness assessment process, is that it is very difficult to find accurate data in terms of the American Indian and Alaska Native population. And not only to find that data, but then to have agreements in place to share that data is often a hoop that we're jumping through as a tribe, because we don't always have access to our own data, and that's a problem. And it's definitely a big roadblock for us. The CTYR decided a few years ago, previously we had been partnering with the county to do our community health assessment and our community health improvement plan. But when we kind of started the reaccreditation journey back in like 2016, 17, our tribe decided that they wanted to move toward a tribal health improvement plan and a tribal health assessment. And so we conducted our first kind of tribally independent community health assessment in 2021. And you know, the goal of that is that we had data that was accurate to our reservation, our community, and that we kind of had access to. And we worked with the Northwest Portland Area Indian Health Board and their Tribal Epidemiology Center to process that data and to bring it back to the community. So they have been a tremendous partner in our work. And as I mentioned before, we also partner with an organization called MPC Research, which we've used for many years and kind of we have a good relationship with. So I think it's just about finding those partners who are going to be able to help you use data in the way that you want to use it. And then also, you know, there's always difficulty in getting access to data that you need.
Any additional questions or comments? If not, I have one that we've heard quite often, especially not just with tribes that are just getting started, but one of the opportunities that we see to improve public health accreditation work around this is how you reach out to your communities, how you educate them about accreditation. And I know Candace and Chelsea, and even Brittany may have some general examples that you can provide. A lot of people that are reaching out for technical assistance, they're asking, well, how do we get started? How do we go about building partnerships? I'm wondering if you can tell us a little bit more about the organizations that you work with. Are they aware of public health accreditation, what it is? And if not, what does it look like to educate those external entities when it comes to working with you and gaining their buy-in so that they can partner with you to go along this journey with you?
I think one thing that has helped us is our clinics are AAAHC accredited to be able to bill Medicare and Medicaid, those types of things. And they have gone through that process well before we were even thinking of the public health accreditation process. And so being able to communicate, they laid the foundation in how important accreditation is. And so kind of tying into that conversation of accreditation, even internally with health staff, but also recognizing that there are differences. I know in annual budgets and with our legislators in our government structure, being able to communicate the avenue of best practices versus return on investment in finances. AAAHC really helps with the finances aspect of it in terms of accreditation and being able to bill for services. There's not always this the same perfect direct link for public health accreditation, but there are still avenues and grants and other ways. But framing it in the way of best practices has helped land both in communities, in some of our partnerships, and we work with county health departments that are accredited as well. But finding ways that individuals understand what accreditation looks like. And sometimes you're just sitting there doing the work to do the work, and that's okay too.
Yeah, I second a lot of what Candace said. Our clinic has AAAHC and PCPCH, so we have a good groundwork of accreditation, and I think our staff is familiar with kind of the process of what all that requires. I also think it helps. We are overseen by a health commission here at Yellow Hawk, which is a group of community members who act as our guiding board, and some of the community members that serve on that governing board were people who were involved in getting PHAB initially. So they have a really strong understanding of what it is and why it's important. But I also agree, you know, at PHAB, people always ask, well, what is it tied to? Do we get money for it? Is there funding, you know? And it is really just explaining like, no, that's not what it is. It's about having a certain standard of public health services in your community. And it's also about being aware of social drivers of health and how all of us as organizations, as partners, as community members can contribute to our health and well-being. And so trying to frame it in that regard. And I think for us specifically, one really cool thing that happened is that our tribal board of trustees, when we started the community health assessment process as a tribe, and when we started kind of the PHAB journey, we created a committee within our tribe called the we call it QUIC. It's the CTUR Community Wellness Improvement Collaborative. And it's a group of different organizations that have some hand in, you know, social drivers of health that are that serve on a committee together. And a lot of times that's who we are able to access to work and have collaborative relationships within the community to do some of these big PHAB projects. So that has been extremely helpful.
Awesome. Thank you so much for sharing. Okay, any additional questions or comments from any of the participants online? Okay, I'm not seeing anything. So on that note, I would like to thank our speakers for this afternoon. Chelsea Halem, Candace Dunlap, and Britton Williams. If you're still on, I want to thank you so much for allowing us to borrow some of your time this afternoon, for sharing your resources, sharing your knowledge, just hearing your stories. It always keeps me motivated to keep going, just to hear the great successes that are going on in Indian country, and just to get to know the people who are doing the work and how we can better support you guys as well. So thank you so much for allowing us to borrow you for this afternoon. I will be sure to collect the presentation materials after today's call, and then we'll be sure to get that disseminated to everyone. So on that note, I would like to bid everyone a great afternoon. We'll give you back 6 minutes to your day. I hope everyone has a really great week, and we look forward to seeing you on our next webinar. Thanks, everyone.